Hi, we are here with Dr. Daniel Petrylak, who is Professor of Medicine and Urology and co-leader of the Cancer Signaling Networks at Yale Cancer Center. He's going to discuss some of the prostate cancer and bladder cancer data being presented at this year's symposium. Hi, Dr. Petrylak, thank you so much for being here.
Thanks for inviting me, Gina. How are you?
Good, thank
Good.
you. How are you?
Good.
Good. So let's start off with bladder cancer.
Right.
What would you say are really some of the exciting data that we're learning about this year?
So I think one of the more exciting presentations is an extension of something that was presented at ESMO with enfortumab vedotin. As we know, enfortumab is a monoclonal antibody that is linked to a chemotherapeutic agent, and we've seen a 40% response rate in patients who are refractory to two different treatments, checkpoint therapy as well as chemotherapy. So what this trial did was it combined enfortumab along with pembrolizumab in patients who were not eligible to receive cisplatin-based chemotherapy. And the objective the anti-tumor shrinkage rate was 84%, which is pretty impressive. Enfortumab by itself has about a 70% shrinkage rate overall, not partial and complete, but overall shrinkage rate. So this is really one of the more active combinations that we've seen. We're also seeing that the median time to progression is about 12 months, which is pretty impressive as well. So I'm really excited about this data. I'm proud to be a part of the trial, and we hope for more information, perhaps a randomized study coming in the future.
Very exciting, thank you. So now I'm going to jump over to prostate cancer. You're the lead author of a poster looking at the association of humoral antigen spread with cytotoxic T lymphocyte activity after sipuleucel T in the phase 2 STAMP and STRIDE trials. So can you give a little overview and discuss those findings?
Sure. So STAMP and STRIDE were trials that were looking at combinations of sipuleucel T with different hormonal agents, enzalutamide or abiraterone and prednisone. And what we did in this study was we looked at the different patterns of immunity that developed with sipuleucel T treatment. Sipuleucel T is a dendritic cell product, and that is raised against something called prostatic acid phosphatase. And there are 3 infusions that go back into the patients. We thought this was all predominantly a dendritic cell process. What we're seeing is, as time goes on, there's something called antigen spread. So the cancer cells are basically lysed. They release antigens aside from PAP. Those include PSA, PSMA, prostate stem cell antigen. So if you look at those, there's a whole variety of different antigens that come out. It turns out that later on, the cancer cells or the patients develop B-cell immunity. They develop monoclonal antibodies to those particular targets. So there may be 2 different ways that sipuleucel T induces cellular death and cellular killing. So this is an important product. I think it's a little bit underused in the treatment of castrate-resistant prostate cancer, mainly because in the past people thought that, well, there wasn't a progression-free survival difference. That really didn't make sense. But now, as we're seeing with immune therapy, you don't need a PFS difference to get a survival benefit. And the IMPACT trial, which was actually now almost 10 years old, demonstrated a survival benefit for CIP-T in patients who are asymptomatic or minimally symptomatic.
Very interesting, thank you. Now, I wanted to talk about the COSMIC-021 trial that's gaining a lot of interest at this year's meeting too. So can you give some background to the COSMIC clinical trial program and then what we're seeing here?
So cabozantinib, the original use of cabozantinib was intended for prostate cancer. And cabo had some really very, very interesting patterns of response. It was showing bone scan responses and improvement in bone pain, and this is what got a lot of us excited. Unfortunately, the COSMIC-1 and the COSMIC-2 trials failed to meet their primary endpoint, predominantly because this was in a very, very refractory group of patients. Cabozantinib is a kinase, and of course kinases have, or what we call dirty drugs, they have multiple actions, mechanisms of action. And one of the actions of cabozantinib is a decrease in myeloid suppressor cells. So it has an immune modulatory effect. By itself, cabo has about a 4% response rate in prostate cancer. Not particularly impressive. Same thing with the atezolizumab. Atezolizumab, it's less than 10%. And we had actually presented some data a couple of years ago looking at atezolizumab as a single agent in castrate-resistant disease. So an interesting survival pattern. It looked like in a refractory group of patients they were living longer, but non-randomized, so you really can't claim anything from that. When you combine the 2 drugs together, you get about a 30% response rate, which I think is incredibly exciting. The question is why? If you look at the spider plots, actually what you see in a lot of these patients is an increase in tumor volume and then a decrease, which tells me this is probably an immune mechanism. The cancer cells or the immune cells are migrating towards the measurable disease, and then they're causing their anti-tumor activity and then causing the cancer cells to die. So I think that there's a lot of interesting questions mechanistically with this. It's potentially affording us another option, but think of it this way, 2 drugs which really have minimal activity separately now are combined together and are showing activity, true synergy.
What do you think the future holds for this regimen? How do you see it best fitting into the landscape?
Well, I see this either in place of chemotherapy or after chemotherapy. These are patients with poor risk characteristics. We have a lot of, as we're treating more patients down the continuum, we're seeing the disease get more aggressive, more liver metastases, more spread to other areas. The most impressive response in this study was a patient who had almost a complete response in liver, which is outside of platinum is not really seen. So I think that there's great potential for this, but either in visceral disease or a combination with chemotherapy or in other areas, but we're excited about it.
Very good. Thank you so much. Now, PARP inhibitors have also been making some headway in select patients with prostate cancer. So this year we saw data from the combination of olaparib and cediranib in patients with metastatic castration-resistant disease. So what's important to know about these data?
So I think it's important to know that with BRCA and with DNA repair mutations, PARP inhibitors are useful for those types of patients. That's only about 20% of all patients with castrate-resistant disease. So we want to try to expand that group of patients to include others. This work was done by Joe Kim at Yale, who is one of our attendings who works in a group, and Joe's really a fine young investigator, and he really should be congratulated on this trial. What Joe did was he took patients with castrate-resistant prostate cancer. They were not selected. We're looking at those molecular markers now, so we don't have the marker data. Randomized them to receive either olaparib or cediranib. Cediranib is an anti-angiogenesis agent. And the theory behind this is that by causing hypoxia, you induce BRCA. And you induce BRCA-like changes in the tumor cells. So this makes them susceptible to PARP. And this is a way for us to expand this out. So what Joe found was when you compare olaparib cediranib to olaparib alone, there's a 7-month difference in radiographic progression-free survival. That's statistically significant. The other interesting thing from this trial is one of our patients who was treated had initially responded to olaparib. He was a BRCA-positive patient. We then put him on cediranib when he progressed, along with the olaparib, and he responded again. So it's further support that this hypothesis may be valid. It's not only being done with olaparib and cediranib, it's also being done with abiraterone. Abiraterone will decrease the DNA repair enzymes. Same thing with immune checkpoint agents. So I think that we have really a lot of areas to explore with PARP inhibitors in terms of developing new treatments and expanding its use for patients who may not be BRCA positive.
Very wonderful insight. Thank you so much. Is there other research that you're authored on this year that you would like to highlight?
So we presented our schema for the KEYNOTE-921 trial, which is a randomized trial comparing docetaxel plus pembrolizumab to docetaxel alone. There have been preliminary reports of this combination showing an increase in radiographic progression-free survival over historical controls, and we're excited about this study. It's more than 1,000 patients internationally. We're accruing nicely on it, and so hopefully we'll have an answer in a year or two as to whether this actually improves survival or not.
That's great. Thank you so much, Dr. Petrylak.
Thank
We really
you.
appreciate you being
Always
here.
a pleasure. Thanks.